I think some of the content of this could be a repetition, could be an overlap, could also be a overview of what has been just talked. So please bear with this. So we're talking about monitoring non-infectious uveitis. Uh, if you look at all the evidences, despite them, the efficacy of these immunosuppressive treatments in uveitis, it is generally accepted that delay in treatment to a uveitis or referral to a uveitis specialist, delay in commencement of immunosuppression, and even inadequate immunosuppression could lead to a poor visual prognosis. And so, central to the management of the ocular inflammatory disease is actually the patient's understanding of the disease and its treatment. Patient education about potentially life-threatening complications, although the percentage is very, very minuscule. And the third thing is reinforcing the importance of regular follow-up in terms of blood tests as well as the follow-up in the clinics. A little brief on the immune inflammatory cascade. Now the understanding is supposed to be very essential. We have mediators that are part of the intracellular and the intercellular signaling that allows the cells to respond based on the past and the present antigen exposures. Secondly, the abnormal regulation leads to autoimmunity and excessive inflammatory responses. Now, there are two components in this response, as we are all aware of. One is the innate response, which is a direct cellular response, and this is involving mast cells and the neutrophils, and the adaptive immune system, which actually involves the antigen-presenting cells and the B and T lymphocytes. Now, acute management often requires down-regulation of inflammatory cells and mediators that are involved in these integrated systems. And the long-term management involves minimizing the excessive healing response. Now, if you look at the clinical management of uveitis in a nutshell, we first have a step one where we classify the entire process. We look at the disease course, we look at the laterality, we look at the character, whether it is granulomatous, non-granulomatous. We look at the location, whether it's in the anterior, intermediate, posterior, or pan. And then we go in to ascertain what is the etiology of the entire process. After we identify the etiology, we look at the immediate control of the treatment, which is mostly revolving around steroids in different routes. And the fourth step is actually to treat for a long-term control. This is the fundament of how we monitor the entire process. And if you look at the aim and goals of the treatment, we are actually looking at a quiet anterior segment, a dry macula, a steroid-free disease-free system, and no recurrences. Unfortunately, this becomes an ideal scenario. If you look at the therapeutic response, while we are on the thing, we normally look for both subjective and objective visual acuity assessments, and also assessments of inflammation in the anterior segment for cells and for the flare. Even assessment of the posterior segment in terms of the vitreous cells, activity in the area of the interest in the choroiditis patch, activity of vasculitis that is involved around it, and of course the disc and the macular status. And the parameters at each examination, if you look at it, we are all doing this every day, it's only to reiterate. Diagnostic side, we have something called as the fundus autofluorescence, which is now the new tool in trying to assess not only the active sites of a disease which might not be visible clinically, and if you're familiar with the autofluorescence pictures, if you find on the edge of a lesion which is totally dark but the edges have a slight hyper autofluorescence, that is a process where you can realize there is the disease activity. That's an active zone. And you can continuously do this non-invasive test at every visit to find out which are the lesions which are healed, which are the lesions which are not healed, or which are the ones which are cropping up during the treatment. So accordingly, you can modify. So if you are dealing with an anterior uveitis case, we normally look for cells, because cells are the one to treat. And every time we try to see in case they have any cataracts or glaucomas, because these are the side effects of these steroid responses. In cases of intermediate uveitis, the visual acuity, the vitreous haze, the cystoid edema in the macula, the vasculitis, or the disc edema are all the signs that have to be mentioned at every follow-up to see how the response is. I normally try to do the autofluorescence almost every week whenever I ask them to come back. Because one of the reasons is that gives me the first sign of a response to the treatment. Posterior uveitis, again, we look at the same criteria as we look at even in pan-uveitis. Now, what we would like to look at is steroids in general are anti-inflammatory and immunosuppressants are immunomodulatory. Now, patients treated with corticosteroids will always rebound unless the disease has run its course. We have seen this in the experiences like acute anterior uveitis or VKH. I think Dr. Rohan Chawla actually demonstrated about the long-term use. I must mention that a sunset sign is definitely a sign which says that the treatment was inadequate. So you have to look at even these responses to make sure that you are adequately covering the disease. Patients treated with immunosuppressants may be able to alter the underlying mechanisms of the disease, which is immunomodulation. And what you do in these cases is you are either waiting it out or suppressing it so thoroughly that the feedback to perpetuate the disease is broken. This is all that we are doing when we are trying to play with the immune mechanisms. And so we were all talking about the International Uveitis Society guidelines, and they all say that immunosuppression is indicated as steroid-sparing agent for patients with uveitis if unable to taper it to less than 10 milligram daily for 3 months. And if you look at the other guidelines, they say that immunosuppression is indicated for certain types of uveitis before corticosteroid dependence is confirmed. That means we are looking at that as a simultaneous first-line treatment, especially like in Behçet's disease, Burshardt's chorioretinopathies, serpiginous, and even in multifocal choroiditis with pan-uveitis, which has a chronic course. Now, children requiring more than 4 times daily topical steroids to control the iritis, children with intolerable side effects from topical steroids, then we have VKH side effects and sympathetic ophthalmia chronicity and side effects. Now, all these cases, they actually talk about using immunosuppression as the first line. So then they came up with these guidelines. Now, the following is actually a study that was done to find out what was the compliance with the guidelines. And this was done by Nguyen et al., published in 2011 Ophthalmology, where they went in through 27 states with about 60 ophthalmologists, and they had a criteria. And now, when you actually look at the story that came out, oral steroids still continue to be at a high comfort level for usage. So when we go through the data, if you look at the one in the purple, is where they actually thought that only 40% were the people who were using immunosuppression, and the red actually indicated the higher usage of the steroids. So what was the conclusion of this? They said that the guidelines were not followed. So they used steroids for too much and too long. And steroid injections used to spare oral corticosteroids rather than immunosuppressants. So somewhere there was a lurking fear about the immunosuppressive therapy. Then if you look at the systemic immunosuppressive therapy for the eye diseases cohort, which was the multi-center retrospective study, if I go into the gist, the most accepted one was mycophenolate mofetil with a 73% control of the inflammation at the end of 12 months. And discontinuing the steroid was in about 12% only. It actually allowed discontinuing in almost about 88%, and in 12% they did use the steroids. So fundamentally, this talks about the safety profile of using the immunosuppressions, and not to have the scare that, we shouldn't be using the immunosuppression as if that is a taboo. So my final suggestions would be that all these suggestions could be a guideline, but it's fundamentally you. So you have to read the guidelines and keep in touch with the guidelines from time to time. You have to look up the doses every time because it's difficult to memorize all these doses. You have to understand the toxicities mostly, and you must follow the monitoring guidelines. Now collaborate with and not just consult with the rheumatologist. This is the most important thing because he and you are both together as one in this entire treatment process. He can do the control of the drug process, you do the treatment of the disease process. And don't overdo vitrectomy surgery or injection just because you know how to do them. Thank you very much.